normal and abnormal morphology of the tissue from which they are derived, meaning that we analyze the cells from some tissue. There are two types of sample collection in cytology. It can be exfoliative and non-exfoliative. Exfoliative is when you collect the samples normally from shedding tissue like the epithelium. You can use the spatula, brush, or others. Even the sputum, it is the kind of the exfoliative sample collection. Even the urine. In the non-exfoliative, sample cells are collected using needles with suction pressure, what we call fine needle aspiration. This one you're going to see it is when there is a palpable mass. In that case, you have to insert a needle and then you collect the sample for analysis. So this is a natural spontaneous exfoliation. We have seen this one for the urine, sputum, nipple secretion, like exudate and transudate. You have seen it in your biochemistry. For example, in pleural fluid, you can see some cancer cells from the lung or pleural effusion, pericardial fluid, cerebrospinal fluid, peritoneal fluid, joint fluid, even the articulation. We can analyze the cells. Even in the CSF, you can find some malignant cells, lymphocytes, neutrophils, and others. For the sputum, the same. So this is what we call artificial enhancing exfoliation. For this one, scraping from the cervix. When you go for the screening of cervical cancer, you can take for sample from the cervix, scraping from the vagina, oral cavity, even on the skin when there is a ulceration. There is sometimes we use the brushing and the lavage. For example, in the bronchus, I've seen it in your clinical skills. In that case, when they insert the tube to the lung, then you do the lavage, gastrointestinal tract and urinary tract. Body cavities fluid, I have seen pleural effusion, pericardial, and peritoneal fluid. So in a non-exfoliative, can have some cysts on the skin, some breast tumors and the ovary, and some solid tissue like body organs and tumors. For this one, non-exfoliative is for fine needle aspiration. So you can ask, what is the role of the cytopathology in clinical practice? Cytopathology is early detection of unexpected disease. It can be malignant, pre-malignant, confirmation of the suspected disease without surgical trauma. For example, I give one example like extrapulmonary TB. When there is enlargement of the lymphoid, a lymph node, for that one you aspirate a fluid, then you go for analysis. For this one, most of the time we found it is a tuberculosis. This one is cost effective because you don't go for the surgical operation, which you need the anesthesia and the other procedures. Whereas aspiration of that material for analysis will give you the diagnosis. So this one is for early detection, even for the screening of cervical cancer. So advantage of cytopathology is rapid. The turnaround the time of the result is around 2 hours maximum. It is inexpensive and it is very simple. And it is better in evaluating the infectious disease. It can supplement or replace a frozen section or biopsy, meaning that you don't need for surgical procedures. There is no injured tissue allowing repeating samples. Cytopathology smears covers a wider surface than that involved in a surgical biopsy. For surgical biopsy is very, very expensive compared to the cytology. The interpretation is based on the morphology of individual cells. In cytopathology, not always we have the final diagnosis. For example, if it is the fine needle aspiration, it can give you it is like a screening, but you have to confirm with the histopathology. For example, if we found in the breast, there is a ductal carcinoma in the breast, you have, before taking the treatment, you have to confirm it with the histopathology. Cytopathology also a challenge. It doesn't determine the size and the type of the lesion of some cases. For example, you can't say on the cytology grading of the tumor. No, this one you need the biopsy. The size and extent, this one it is limited in cytopathology. The factors that determine the appearance of the cells, first of all, type of the technique used. It is a pap smear, sputum, urine. Level of maturation of the time of the cells correction. It is also depend on nature of the parent tissue. For example, if it is a soft tissue, cyst, or solid organ. Medium of exfoliated cells. Interval between the stain of exfoliated cells and the correction of the sample. For example, if you correct a sample for FNA, and then you delay for fixation about 5 minutes, in that case there will be autolysis. So it will be difficult to know the diagnosis. Type of fixative. Which type of fixative I've used? If it is alcohol, on heating, stain, if it is the PAPS stain or difficult stain or others. Processing of technique, this one, the steps. So this one will affect the morphology of the cells. Let us say about the slide preparation. We have corrected the sample, now on the slide preparation. There is what we call conventional preparation, liquid-based preparation, and cell block preparation. Conventional preparation is that when you take a sample, then immediately fix on the slide and put it in a fixative. This one is done on the pap smear. And this one, convention is not expensive. But when you go in the developed countries, they don't use convention, they use liquid-based cytology. For liquid-based cytology, sample is collected and put immediately in a fixative, what we call preservative vial for processing, instead of being smeared on the slide. For this one, you don't put the sample on the slide immediately. You put the sample on preservative vial. Liquid-based cytology.
Excuse me, sir.
Okay.
Excuse me.
You're welcome.
I don't know if I'm the one who has a problem. I'm not seeing the slides.
You don't see the slide.
Yeah, I'm not. I don't know if I'm the one who has a problem, but I don't know. Maybe slides are not.
Maybe it is the problem of internet.
Some can see them.
Can you see now the slide?
I'm not seeing them.
Maybe to let be his problem. Somebody seeing them.
What happened?
Maybe it's my network problem.
What about the others?
We are seeing the slides.
We can see the
You're
slide.
saying
Are you seeing this slide?
yes.
Yes,
Yes.
now we can see the slide preparation on the chat.
You see them?
Yes, we are
Yes,
seeing
we
you.
can see them.
Okay. So I said the liquid-based cytotoxicology is better than conventional preparation because this one you see the cell clear. Whereas in convention, most of the time it is obscured by some fluid in the others. There is what we call a cell block. A cell block is when you are, for example, when you are aspirating a cyst, and then you don't find the cells in the cyst. In that case, you do a centrifugation, and then you take those samples and you put it in formalin. Then you shift from the cytology, then you go to the histopathology. Now you will use hematoxin and eosin. We'll see them in practice what is a cell block. For example, you can have some fluid, peritoneal fluid, then you do a centrifugation, and then what you found, you put it in a formalin, then you go for the processing like hematoxin and the eosin. So the stain used, there are two types of stain used in cytology, Romanowski type. For this one, it is for air-dried slide. When you use it, you don't need to put a fixative. We'll add Papa Nicolau stain. It is for immediate fixated slide. Romanowski type, for this one, cytoplasmic are better preserved. Nuclear and the nucleolar features are less preserved, meaning that in the case of Diffquick, you see clear the cytoplasm. Whereas in Papa Nicolau stain, you see clear the nucleus and nucleolus. But this one, it depends on the choice of the staff. There are some people, they prefer Diffquick, and some staff, they prefer Papa Nicolau stain. This Papa Nicolau stain is found from a doctor called George Papanicolaou. It is an Italian. It's the one who has discovered that type of pap smear. Pap smear is used for screening of cervical cancer. We'll see it in gynecological pathology. With the screening, regular screening of the cervical cancer, we can reduce the mortality related to the cervical cancer through the screening. So this one, it is very important. You must know as a physician, you must know screening of cervical cancer. This one, it is very, very simple and not expensive. So first of all, you must have a sampling device like a brush or spatula. This one is to scrape the surface of the woman surface to collect a sample of the cervical cancer. For collecting the sample, you have to use a spatula. And you determine if we are going to use conventional pap smear or liquid-based pap smear. When you are going to use the conventional pap smear, immediately the sample is made into the microscope slide and then put in a fixative. The fixative here, it is alcohol 95%. This one, the fixative used in cytology, alcohol 95%. If you're going to use the liquid-based cytology, immediately you put the sample in that preservative vial, and then you go for the processing. For pap smear in cervical cancer, we don't use Diffquick. We use Papa Nicolau stain. The liquid-based cytology has a higher sensitivity than conventional pap smear. So we are going to see them in practice. We're going to see the slide stained by conventional and liquid-based cytology. A liquid-based cytology sample is collected like any other pap smear, but after the collection, the cervical cancer to be screened are transferred into a preservative vial. This one we have said. In the case of the liquid-based cytology, we don't see any desirable or scoring material like blood, mucus, and the others. For example, you see those images. This one is where I've used conventional pap smear. For this one, you see clear the cells. This one is liquid-based cytology. So here it is the normal cervix. This is the cervical canal. It is where they do the sampling. Here it is ectocervix, and inside is endocervix. Then you collect a sample here. This is the brush used for collecting sample. Some spatula here. This is a bottle containing the fluid for cytology, for liquid-based cytology. For staining, it can be even automated or manual, depending on the technology you have. We have so many samples with high technology. You can use an automated to stain. And for this one, liquid-based cytology, you must have a cytocentrifuge for this one to collect the samples. Cytology screening for cervical cancer. This one is very important for you. I have said it has decreased the morbidity and the mortality related to cervical cancer. Here they say pap smear are not perfect because you can't do the grading. You just know it is, there is no marginance or marginance. But they say there's some false negative rate estimated to 30 to 50%. And it requires adequate cytological review. Perhaps also to confirm the diagnosis, you must have also a biopsy from the cervix. Patient instruction before taking the sample, because this one is very, very important. They schedule the examination 2 weeks after the first day of last menstrual period. It is preferable because during menses, blood may obscure significant findings. This is why they say 2 weeks after the day of last menstrual period. Before taking the sample, do not use vaginal medication, vaginal contraception, douche for 24 hours before an appointment, because if you're going to cleaning on the cervix, during the cleaning, you remove the cells. But this one is a big challenge in practice. To tell the woman to come to the hospital without douche, it is a big problem. This is why in some countries, they encourage self-sampling. A woman herself can take the sample. A sexual intercourse is not recommended the night before the appointment, because in that case here you can find some spermatozoid cells. This is why it is not recommended. So taking sample is very, very important, because once you fail in the testing of the sample, you also fail for the diagnosis. A specimen should be obtained after a non-lubricant speculum is inserted. You don't put lubrication in the speculum. An optimal sample includes cells from ectocervix and endocervix because you can find malignant cells on the squamous cells or columnar cells. The sample should be obtained before application of acetic or legal iodine. Acetic acid also is used for screening of cervical cancer, what we call acetic visual inspection, or legal iodine. This one you see some acid white lesion. When it is white, in that case we found that there is maybe a lesion on the cervix. So before, meaning that a sample for pap smear should be obtained before application of that acetic, because if you put the acetic and then you collect the sample, in that case, the cells will be obscured by that acetic acid. And this acetic acid, it must be 3%, 3 to 5%. If you don't use 3 to 4%, you will burn the cervix, and this one you will be in court. It is where the lib will call you for the malpractice. So before application of acetic acid, be sure that it is 3 to 4%. Require adequate patient and physician follow-up. This one is not important. What must know who to screen. Who to screen is any woman with a cervix who has ever had sexual activities. If there is no cervix, there is no need of screening. You can't go for screening for a children of 9 years. When to screen? Start 3 years of onset of sexual intercourse or by age of the 21, whichever is first. So minimum age is 21, but if there are some exception, even at 16, depending on there are some people at the age of 16, they have several partners. For this one, you can even do the screening, but in the box, we say 21. Risk factors associated for cervical dysplasia: early onset of sexual activity, multiple sexual partners, tobacco, or oral contraceptive. This one, they are risk factors. Doesn't mean they are real causes. Frequency of screening yearly until 3 consecutive non-pap smear. Then may decrease to every 3 years. Annual screening for high-risk women is recommended. When to stop routine screening? Over the age of 65, there is no need of screening. When there is a 3 consecutive normal pap smear, no abnormal pap smear in last 10 years, no history of cervical or uterine cancer. Hysterectomy, if there is no uterus, there is no need of screening. So this one, it is anatomy, you know. This one, endocervix is drained by columnar epithelium. Ectocervix is drained by the squamous epithelium. This is the cervical canal. This is an endometrial cavity. This is columnar junction. And below here, it is the vagina. So on the microscope, what we see, this one is an image of histology. But this one is an image of the cytology. For this one, you see superficial cells. You see those squamous cells. They are pink or red. There are some intermediate cells. There's some parabasal cells. You see they don't share the same morphology. And then there's some basal cells. These are normal cells found in ileum on the ectocervix. You see, it is not easy to differentiate for the first time. But if you see clear, this one is pink. You see the color of this one is different from this one. And even the shape. These are parabasal cells. These are the basal cells which are here on the basement membrane. These are parabasal cells. Intermediate cells, there's one blue. Superficial, this one pink. This one, it is endocervix. You see the columnar cells. But on the cytology, it is like this one. You see the brush here. See here. These are columnar cells. So once you have those columnar cells, you have those parabasal cells, intermediate cells, meaning that you have satisfactory sample. These are endometrial cells. You can find also some the lymphocyte and some neutrophils. For this one, it is bad collection of the sample. On this one, I found some spermatozoid. This is a normal smear. So how to know if it is abnormal? For example, these are metaplastic cells, abnormal. Abnormal cells, pap smear, you see the cells are pleomorphic. There is an increase of nucleus compared to the cytoplasm. For example, if you see this one, the nucleus is the cytoplasmic nucleus cytoplasmic relation is higher because here there is an increased size of the nucleus. And if you compare to this one, you see clearly the cytoplasm. And this one is normal. This one is metaplastic, meaning that there's some changes, and those are neutrophils. But when you see this one, this is a malignant, because the nucleus is increased in size compared to the cytoplasm. And you see some cells are large than the other, what we call pleomorphic. So I don't want to go in these details for diagnosis of the screening of cervical cancer because this one requires attention. But what you must know is that to say there is abnormal cells, we focus on the size of the nucleus. The system used for reporting that pap smear is called 2001 Bethesda system. For this one, before they say you must have satisfactory specimen. Satisfactory specimen, squamous component more than 70% of the epithelial cells. Presence of endocervical and the transformation component. This one you say, I have an adequate sample. The problem here, it is for the gynecologist, it is, most of them, they don't know what is adequate sample for pap smear screening. So as we have seen, you must have 70% of squamous cells. You see some columnar transformation component, meaning that when you take an sample, you rotate around the ectocervix and also you take on the endocervix. And you do it gently. There's no need to make trauma to the patient. A reporting, here it is what you will see in your report when you will be in hospitals. Negative for intraepithelial lesion or malignant, meaning that this one it is normal pap smear. Meaning the cells are normal. There's some epithelial abnormalities, what we call atypical squamous cells, of undetermined significance, as CAS can exclude high squamous intraepithelial lesion, what we call high C, low-grade squamous intraepithelial lesion, high-grade intraepithelial lesion, squamous cells carcinoma, and atypical glandular cells. In case you see a report of atypical squamous cells, low-grade squamous cells, in that case you have to do a small biopsy on the cervix, and then you do histopathology analysis. Before we go to the FNA, you will read on this one. This one. Apart from that pap smear, there is another one, cheapest system of screening using acetic acid, what we call via visual inspection acetic acid. This one you read on it, and legal iodine. These are used also for the screening of cervical cancer. So for this one, acetic, you see the acetowhite lesion. When there is acetowhite lesion, then you say it is suspicious. In that case, there is an algorithm, you can do the pap smear. When the pap smear becomes suspicious, then you go for the biopsy. Because acetic acid, in the case of cystitis, it can also be a positive, then you can have a confusion with the malignancy. This one, acetic acid, is preferred in a poor country or developing country because it is cheaper. It is cheaper than the pap smear. It is even done in the health centers, district hospitals for screening of cervical cancer. Any question about the screening of cervical cancer? Any question? Any question?
Question.
Yes.
Teacher, about how to screen the cervical cancer.
How to screen for cervical cancer?
Yeah, you said that they are the person who has ever had sexual intercourse. I'm confused. I want you to explain clearly about who to screen the cervical cancer.
First of all, it must be a female. It must be at the age of 21, and it must have sexual activities. For example, if you go for a lady without sexual activities, in that case, you can't do the screening of the cervical cancer because the high risk is for those who have multiple partners. For example, you will see it, there is what we call human papilloma virus. Most of the time, not even most of the time, it is classified in sexual transmitted disease. So, and that cancer of the cervix, most of the time it is due to the HPV, human papilloma virus. This one it can also found in male and female. Okay.
Yeah, thank you.
Sorry, teacher.
Yes.
Sorry. Can you stick back on the acetic acid screening about the findings and the interpretation?
You have said this one is your assignment. That case of acetic acid is what we call acetowhite region. When it is white, meaning that there is a region that is suspicious of the cancer. Okay? And in your free time, then you'll go and read about screening of cervical cancer using acetic acid or rigor iodine. Okay? Okay?
Yes, teacher.
Okay, thank you.
Okay. So another technique used in cytology is fine needle aspiration. I like this fine needle aspiration in the diagnosis of extrapremolar TB in the lymph node. Here at Siashika, maybe we can find 3 cases per week of TB diagnosed by fine needle aspiration. The patient come with the lymphadenopathies, then we put a needle, we aspirate, then we analyze for microscopy, then we put it in the oramine or gene expert technique, then we found it is tuberculosis. Immediately, the patient will start the treatment. This one is cost effective because if you go for the biopsy, it will be expensive. You need surgery, anesthesia, a long time of histopathology. Whereas when you use the fine needle aspiration, immediately the patient will start the treatment. So this is a shared experience with the fine needle aspiration or practice. So fine needle aspiration, first of all, an indication of fine needle aspiration, you must have a palpable mass. Once you don't have a palpable mass, you don't do the fine needle aspiration. Most of the time we do the fine needle aspiration of those lymphadenopathies, thyroid masses, and breast, and some cyst on the skin, parotid gland, submandibular gland. For this one, for the aspiration, we need the needles. We need the needles of 22, 23, 25, but most of the time we use 23. Maybe you don't know 25G is smaller than 23. 22 bigger than 23. 18 is bigger than 22. So in the fine needle aspiration, we use most slide, the small slide. Some people they think when you use the big, some people they think when you use a big needle, it is where you collect a sample easily. It is different. The small needles are better in fine needles aspiration than the bigger needles. We can also use some 1.5 inches long needle. This one is used for radiologists. For example, if there is a tumor on the kidney, you can insert the needle through the ultrasound guidance, and then you collect samples. The diagnostic material is in a needle and not in the ceiling, even the stick region. So we've seen that in practice. After aspiration, then you shed the diagnostic material on the slide. So to do the fine needle aspiration, you must have the clinical skills as you have done. You must be familiar with the anatomy. For example, if you see a mass on the carotid, you must be careful. If you put the needle on the carotid, the patient will die. You must know some sensitive area like areola of the breast, you can't insert the needle in the areola of the breast because it is very, very painful because of those nerve endings in that areola. Physical examination, you must have the skills of examination of the patient, and then good knowledge of normal cellular element, histology and the cytology, and then clinical practice, and then ability to combine microscopic images and the clinical features, then you give the diagnosis. Because in the pathology, it is not only on the microscope, you must also have the clinical skills. This is an image of the papillary carcinoma of the thyroid. This one, the cytology, and this one is the histology on the biopsy. The same here, image of the cytology, image of the biopsy. So you can ask who should perform the FNA? Every clinician, cytotechnologist, radiologist, pathologist. But the pathologist, the one who examines the patient, does aspiration, make the cement, the cytology. The pathologist is the best and in a good position to give the diagnosis of FNA because he has both clinical skills and microscopic skills. I have said indication is the palpable mass. May be around over 0.5 of diameter. It can be done outpatient and inpatient. You can do FNA in a room of consultation, even on the bed of the patient. Most of the time, it is done on the thyroid, breast, lymph node, salivary gland, some soft tissue lumps. For the lung, you can use the intra-abdominal. So even on the lung, you can do the biopsy. Even intra-abdominal and the peritoneal by radiologic images using the CT scan, ultrasound, and fluoroscopy. But most of the time, it is this one, the thyroid, the breast, salivary gland. Because this one on the lung, you must have a radiologist around or someone specialized in lung disease. Limitation, it is not done on the bone. And it doesn't make staging, grading of the tumor. For example, if it is a lymph node, you can't say it is a diffuse or nodular lymphoma. No, to show that it is a malignant. Complication, they are very, very rare. Very, very rare. Even here, it is written the needle trauma, interfere with surgical pathology. You can have pneumothorax on the lung, hematoma, pain. But this one, it is very rare. In general, there is no complication with fine needle aspiration. It can happen, but it is very, very rare. Advantage of fine needle aspiration is fast and it gives the early diagnosis. I have said for the TB, for breast cancer, immediately you see it is malignant or benign. Then the patient will return home saying that even though the tumor is not operated, but it is benign. And no anesthesia. And it is accepted by patient and doctors, and it is very accurate and fast and inexpensive. The sample taken for the fine needle aspiration, it can be used for Cerebral, what you have said that you do a centrifugation, then you put it in formalin, then you go for analysis like in histopathology. It can be used for histochemistry. It can be used for immunohistochemistry. Electron microscopy. It can be used for flow cytometry. Flow cytometry is used for the diagnosis of hematological cancer. It can be even used in molecular pathology. We do the PCR polymerase reaction and equalization. Sample of the FNA can be used for other technique for the diagnosis of a disease. Here there are some images on the cytology. It is what happened. This is a kind of a cerebral. It looks like histology. Any question before we leave the FNA? Then you go for the cytology of body fluid.
Excuse me, Prof.
Yes.
I wanted to know the difference between non-exfoliative type of sample collection and this final needle aspiration.
So do you have babies in class? I see babies are crying. So the difference between exfoliative and non-exfoliative. Non-exfoliative is that one you say for the FNH, because for this one we use aspiration of the needles. Those for exfoliative, the sample is collected using the spatula, like those in the pap smear, those in the fluid, from peritoneal fluid, those are called non-exfoliative. Exfoliative is for FNH. Okay. Is it clear? Is it clear the difference between exfoliative and non-exfoliative?
Yeah, it's clear.
Okay. Another question about the FNA? So if there's no question, let us see the cytology of body fluid. First of all, you must know what is body fluid. A body fluid, here we say, it is about those peritoneal fluid, joint fluid, those sputum, urine, CSF, these are called body fluid. Those body fluid are used for the early detection and screening of the disease. For example, if you found in the urine some malignant cells, peritoneal fluid, you can find some malignant cells or inflammation, features of the TB, and or another inflammation. For example, you can have fluid in pleural effusion. In that case, you aspirate and then do sample for the lab for analysis. In that case, they tell you that it is an inflammation or it is a malignant. So here we see those mesothelial cells from the peritoneal fluid. This is an image of those mesothelial cells. In peritoneal or pleural effusion. I don't ask you to go to memorize those morphology of those cells. I know it will be very hard for you, but what you must know is just when you see a body fluid, you send the sample to the lab for analysis. In that case, they will tell you if it is an inflammation or malignancy. The pathology is the one to know those morphology of cells. Because they don't ask you to know the difference between those adenocarcinoma, benign No. What you must know for this one, body fluid, it is that you send sample to the lab, then they tell you some condition. Is it an inflammation or is it a malignancy? Here there are some, for example, this one, tuberculosis pruritus. That one, there will be a high number of cells. You can find necrosis. And this one, you can take a sample, they say 1 milliliter, and then you send it to what we call gene expert to include the tuberculosis. Rheumatoid arthritis, you can find some necrotizing granuloma inflammation, and then pathologist here will say the morphology of those cells. If they found some macrophages, neutrophils, lymphocyte, they say it is an inflammation. In the pleural effusion, you can find some malignant mesothelioma. Mesothelioma is the malignant tumor of the pleural effusion. For this one, the pathology will see the morphology of the cells, then will give the diagnosis. Here it is the pattern of the cells, cell pattern. This is for pathologists. With a short time we have here, you can't memorize those things. So, but you must know here it is when there is a pleural effusion. In men, most of the time it is lung tumor, gastrointestinal tract, pancreas. You can find some the ovary metastasis, lung and breast. The peritoneal fluid can find some ovary, intestinal tumor, pancreas, and others, even the uterus on the prostate. For this one, it is to know you can find a tumor on the liver, and then there will be peritoneal fluid. In that case, you aspirate that fluid, and then they go and they look for if there are some malignant cells in that peritoneal fluid. So these are some cancers diagnosed on the body fluid. I don't ask you to memorize. For example, this one is some signet ring cells found in pleural effusion. This one it will be a feature of the gastric carcinoma. Of those, here it is where they diagnose the follicular lymphoma, large cell lymphoma, but this is not your task. Yet the difference between those mesothelioma and the metastatic adenocarcinoma. For this one, they have found some malignant cells in the peritoneal fluid. But as I've said, at your level now, I don't ask you this one. It is just to communicate that with that fluid, we can do some several. So this is the end of the presentation. In a summary about the body fluid, what I can say is that in case you found a body fluid, please send sample to check if this one is inflammation or if, for example, in peritoneal fluid, pleural fluid. In pleural fluid, you can differentiate a malignant and an inflammation. And if it is tuberculosis, you can take 1 milliliter of fluid then you send it to the lab. Another experience I can share with you. Last week on Monday, I was on the duty. I found a man with a lateral neck mass. In lateral neck mass, I have done an FNA because it was suspicious of TB. Take an FNH, I take a steroid for oramine, and I aspirate 1 milliliter of liter for gene expert. For the microscope, there was necrosis, caseous necrosis, lymphocyte, and macrophage. Oramine was negative. With that caseous necrosis, it was suggestive of TB. And for oramine, it was negative. Gene expert, it was positive. After that, immediately confirmed the diagnosis, tuberculosis, and the patient has started the treatment. So this is one example of the role of in practice. There are some peritoneal fluid, they come, they say maybe it is a TB, and they found some there, that is peritoneal fluid. So for the technique, the steps of staining, this one we see them in the practice, because when you explain it here, it is very difficult to understand. And I wish if this systemic pathology would have enough time for going to the lab, then you see how the pap molecular stain, for the peritoneal fluid, how to perform FNAs. I wish we will have a time for that period of practice.
zigenda mnyi bajya kubaza ikibazo pe network zigenda kubaza ikibazo. Yes.
Any question?
Yes.
Yes. I have.
Welcome.
Teacher, question. I'm not well known about the difference between exfoliative and non-exfoliative techniques.
Who can explain? Because it is the second time you ask that question. In the audience, who can explain to what the difference between exfoliative and non-exfoliative? I have said, who can give us the explanation? Ask that.
I try. Can I try?
You are welcome.
From what you said, exfoliative and non-exfoliative. For exfoliative, for the tissues that can be obtained by the spatulas. For example, we were seeing on the cervical cancer. And about non-exfoliative is when we use fine needle aspirations to get the body fluids from inside. That's what I do.
Yeah, very good. For those thank you. For those pap smear, urine, sputum, peritoneal fluid, these are called exfoliative collection. Non-exfoliative is fine needle aspiration. Okay.
Question.
Yes.
I want to know about the igituntu gisanzwe and the extrapulmonary tuberculosis. The difference between them.
You have done it in your clinical skills. There is a pulmonary tuberculosis. This one it is in the lung.
Don't know how the extrapulmonary tuberculosis. Sorry?
Pulmonary tuberculosis, it is within the lung. Extrapulmonary, it is out of the lung. You can find TB in skin, bone, liver, lymph nodes, and the other organ. This is what we call extrapulmonary TB. The most common is pulmonary TB, but currently we are seeing some extrapulmonary TB. But public health focus most of the time on the pulmonary TB, but there is also extrapulmonary TB. There are so many cases, meaning that a TB is found out of the lung. Sometimes we found even the lung is clear, there is no TB, but the TB is only in the kidney or in the lymph node. Okay? Is it clear?
Yes.
Okay.
Yes.
I have a question too.
Yes.
It's like a suggestion. I wonder during the presentation you kept saying some things are above our levels and we are not asked to memorize them to our levels. I wonder if you would tell us what you are required to memorize and to know on our levels considering this in the whole presentation.
Yeah, you know, pathology is very big. There's something I give you as an information. For example, I can't ask you to tell me the difference on the cytology, mesothelioma and adenocarcinoma. No. But what you must know, in case there is a pleural effusion, you must send the samples to the lab for identification if it is an inflammation or if it is a malignant. But at your level now, I can't ask you to differentiate those morphology of mesothelioma and adenocarcinoma. Okay?
Yeah, thank
What
you.
next if we found this information on malignant?
Sorry?
What should be the next step after knowing that the report from the lab, if it is malignant, if they confirm it's malignant or inflammation, what the next step for us?
It will be the treatment. This is the role of the lab, to guide the treatment. If they tell you it is a tuberculosis, immediately you go for the treatment of the tuberculosis. If they tell you it is an inflammation, in that case, you know it is not a cancer, it is not a malignant. When they say it is a malignant, in that case, you go to the treatment of the malignance. Okay?
Okay.
Question.
Yes.
In the breast, while performing fine needle aspiration, you said that you don't pass the needle around the areola because it's painful.
Yes.
So I was asking, where does it pass?
Sorry? You know the anatomy of the breast?
Yes.
And the areola is around the nipple. So when you insert the needle, you don't touch the areola. You go in the other part out of the areola.
Okay.
And again, if the mass is around the carotid, you said we don't need to put it on the carotid because patient will be dead. So what to do after finding around the carotid.
You must be careful. You must palpate, and when you say you see it is preservative, you don't insert the needle where it is preservative. You go out of that preservative region. You must be careful. This is why I said to do the FNA, you must have some knowledge of the anatomy. Okay?
Okay.
Any question? Any question?
No question.
Any question?
No question.
So if there is no question, in the afternoon at 2 p.m., we are going to see the pathology. And I have a question. Can you assess the Moodle?
Yes.
We will check.
Okay, you check, then you tell me if we can see the content on the Moodle. Okay? So in this afternoon, we see the pathology, we see the lymphoma and those leukemia and the myeloma. Okay?
Yes.
Okay, see you at 2 p.m.
See you.
Okay.
See you.
Yeah.